Hello and welcome to the podcast on emergency management of severe trauma. This podcast is produced for the Critique website. The primary objective of this talk is to assist with the development of an aide-memoire for the initial management of a patient with severe trauma. This internationally adopted approach has been developed so that when the unwell trauma patient arrives at your door, there is a systematic team approach with a common language to the initial management. The approach can be divided into 5 stages. The first, know when to activate the trauma call by way of identifying specific criteria. Next, the use of a primary survey ensures fast, simple, and systematic evaluation of the patient. Thirdly, in conjunction with the primary survey and identification of life or limb-threatening problems, the need for immediate intervention. Systematic elimination of problems by repeating the primary survey when conditions change and in due course proceeding to the secondary survey, stage 4. And finally, to commence the arrangement for definitive care for the identified injuries, and most commonly transport to a theatre or intensive care setting. As seen from the information on trauma presentations within Australia, less than 0.3% of total presentations result in death. The difficulty is in identifying those cases that need the expertise of a full trauma team and, more importantly, being able to identify this early. Being able to identify this can be far more difficult than it sounds, and as a result, most hospitals now have a trauma call system. There are various systems for this, but one example is a colour-coded system, with red for severe, life or limb-threatening, orange for moderate, and green for lesser trauma. The activation of different codes may result in the presence of members of respective teams with different levels of expertise. These trauma levels are composed of several types of information. The first is the mechanism of injury. What has happened, how long ago, what treatment has been given so far, and the estimated time of arrival. This will almost invariably allow for a more efficient setup. Specific triggers with the mechanism of injury, anatomical and physiological indicators may activate the trauma call. Mechanism of injury alone can activate a trauma call. Some examples are listed here, and as well as mechanism, consideration needs to be given to the expected patient numbers. Anatomical considerations listed here, and whilst varied, include spinal cord injury, burns, certainly of more than 20% of the body surface area, and most significant penetrating injuries will justify a trauma call. Physiological considerations include not only hemodynamic instability, but also the extremes of age, both young and old, and of course pregnancy. So the relevant trauma class has been activated, the patient has arrived. Now what do you do? Well, the key is a systematic approach enabling detection and early management of life and limb-threatening issues. A key point being that the team can't move on to the next step, for example definitive care, until sufficient resuscitation has occurred. If the patient condition changes, then start again. Start with a primary survey. This approach can limit severe injuries being missed. Much evidence points to the benefits of effective resuscitation during the golden hour. Immediately after a trauma, there will be a pre-hospital response. This time, accompanied with a severity of trauma, will be out of control of the trauma team. Once retrieval is underway, the rapid administration of resuscitation measures has been shown to reduce the incidence and severity of delayed sepsis and multi-organ failure. An effective, systematic approach in the early presentation is key for optimal patient outcome. The primary survey is taught by many governing bodies, and whilst there may be some slight discrepancies, it's fair to say that an ABCD approach is universal. A is airway with C-spine control, B for breathing and ventilatory support, C for circulation and control of major hemorrhage, and D is for disability and involves neurological assessment. And of course, don't forget glucose, even in trauma. There may be a reason that the MVA happened in the first place. So fix the life-threatening problems as they are found. These problems will be found early with a well-conducted primary survey, and even better, they will be afforded the correct priority with the ABC approach. Understandably, a well-versed trauma team may approach the ABC approach in union. However, securing a definitive airway must be given priority over treatment of the blown pupil, for example. For extra detail on the primary survey, consider how you might assess each component and what emergency management may be indicated. So to start with, the airway. A look, listen and feel approach is reasonable here. Look for obvious trauma, visible foreign body, or listen for signs of upper airway obstruction. Feel for exhaled air. In terms of management, the head tilt chin lift maneuver is generally contraindicated due to the need to protect the C-spine. An array of airway adjuncts and definitive airway are available depending on the physician's skill set and the patient requirements. Don't forget that C-spine immobilization can be accomplished with a dedicated second person, and also a two-person bag mask ventilation technique may deliver more effective tidal volumes. The achievement of a patent airway and avoidance of hypoxia, most commonly with simple airway maneuvers and adjuncts, is essential and the most likely intervention to reduce morbidity and mortality. However, an airway specialist who is able to follow a difficult airway algorithm may be required before one can effectively complete initial resuscitation. And don't forget, although the surgical airway is the last resort, if it's indicated, it does need to be done early. Assessment of breathing with a look, listen and feel approach is effective. Check for work of breathing by way of tachypnea and use of accessory muscles. How effective is this work at producing an adequate minute ventilation? And finally, the distal effects of this breathing. If the patient is alert and communicative, it is likely that the ventilation is adequate. As with the airway, a deficiency in ventilation, once found, needs to have intervention. Ventilatory support includes supplementation of oxygen, non-invasive and invasive support. One major caveat here is the burn inhalational injury, which needs consideration for an early definitive airway before airway swelling occurs. With circulation, a quick, effective assessment for adequate cardiac output and intravascular volume is required. Use of these indices for cardiac status and circulatory inadequacy can be performed rapidly. Importantly, the use of neurological function, when good, can suggest effective circulation, but when poor, may be multifactorial. Similar principles apply to the urine output. Further assessment, whilst usually performed in the secondary survey, can include select use of ultrasound windows, for example, performing